where the lesion is, you know exactly what the physical exam is going to sound like, exactly what this child's presentation is going to be. So I need you to think, where is the lesion for all of these things? A lot of introduction slides on this one. I know this has a lot of slides because there's going to be some review from Dr. DeBoer's class. So, did you guys learn a lot about, or did you learn from Dr. Leggett fetal circulation? And we're just going to make sure, because if you don't understand fetal circulation, we're going to have a hard time, okay? So question 1, is a foraminovalle and an ASD, ventroseptal defect, the same thing? No, right? So if you're thinking back, so the fetal circulation, the foraminovalle, it's the shunt that allowed the higher pressure on the right side, so it looks like this too, the right side, to go bypass the lungs and go into the left side. So, but not all of that does that, right? The majority will bypass. A little is still going to go down into that right ventricle, because you remember from block 1, no flow, no grow. So I need a little bit of flow to that right ventricle to continue. So a little bit. The majority is shunted across your foraminovalle to bypass your lungs. Second place, your ductus arteriosus. A little bit went down into that right ventricle and it's going to go to the lungs, but you don't need all of that even that went there to go to the lungs. So you bypass the lungs again and you're going to go straight out into the aorta. So again, a little bit, like 5 to 10% will still go to the lungs, but you're bypassing again directly to the aorta. This is when you're trying to reverse that. You need to keep this open, so you want oxygenated blood. Backwards, you use prostaglandin E, right? Prostaglandin props the door open. Prostaglandin props. Okay? Then the ductus venosus. In your ductus venosus, you have blood that is coming back after it is circulated, and you're going to basically bypass the liver completely. So if you think, really functionally, what 2 organs have I said that we are going to bypass as a fetus? My liver and my lungs. Wait a second, we had block 1 where we talked a lot about babies and hyperbilirubinemia, and then all that lung stuff, respiratory distress, transient tachypnea of the newborn, right? So the 2 organs that we bypass as babies take a hot second to turn on, because we're going from fetal circulation to not fetal, neonatal circulation. Okay? And that is some of the reasoning. We bypass their function. The placenta was doing it all. The placenta was just taking over all the functions of the lung and all of the functions of the liver. So the 2 things that bypassed from this fetal circulation are the things that babies are going to have problems with right when they come out. So we'll take a look then at that foraminovalle. It was trying to go, or it was going as a fetus, high pressure right side to low pressure left side. Baby takes that first breath, all of a sudden the lungs start to fill, the vasculature of the lungs. It is now higher pressure, left to right, so that shunt closes and you can no longer go. And so if there's an opening, it's going to go left to right instead of right to left at that point. That is what you are going to see. So reminder of the 3 places. Ductus arteriosus bypasses the lungs, the foraminovalle that also bypasses, and then your ductus venosus. It's bypassing your liver. What happens as a neonate then? Those same 3 sites become ligamentum. So these remnants, you should have a ligamentum arteriosum, you should have a ligamentum venosum, so there should be still those remnants. What happens when there's not those remnants and they stay open is where you get into some of the pathology. Foraminovalle that is still open, now allowing left to right. You have the PDA that has this runoff from your aorta backwards. All of those things that happen when fetal circulation does not finish closing. So a reminder, if you understand those things, it's a whole lot easier to work your way through a lot of these other lesions. Okay, so some basic reviews of some things. So when you're born, all of these pressure differentials have not completely made themselves known yet. Right? So just because you took a first breath doesn't mean everything immediately switches. So it takes a few days for some of these shunts to close. It takes a few days for all of these pressures to be what they need to be. So that is why we do serial exams, meaning several in a row, not like eating cereal. Serial exams after they are born to make sure that we are listening for that change in physiology. That's why the NICU exists, because the physiology of a neonate is much different. Certainly if you have a super large hole somewhere, you are going to be able to hear that right after birth, but you really might not be able to hear these teeny tiny defects until all of the pressure differentiation has settled out and it's functioning like you put your thumb over a hose, and now it's really loud. Because it's small, but it's loud. What is the baby then going to present with? Well, the baby is having to work harder if there's a hole somewhere to overcome that need for oxygenation. So you're going to see them have an increased circulatory volume, so they end up a lot of times tachycardic, they end up sometimes tachypnic, you can see hypoxic, or in addition you see them sweating with feeds. This is like their exercise, so they're feeding and they're sweating, like, ooh, right? It's not because they're outside necessarily and it's San Antonio and it's 112 and mom's breastfeeding, totally different reason. If you see a baby that looks like they have run a marathon after taking a bottle, that's the baby that we're talking about. Are you sweating with feeds? And then are you failure to thrive? So if you're calculating, they have taken all of these ounces every 2 to 3 hours, they've done all of the things they're supposed to do, they don't have GERD, they're not having a loss of output. You take a urinalysis, there's no protein loss. Where are the calories going? You need to think, is it somewhere in the circulatory system? So that would be one of the things that you see on exam. Sweating with feeds, failure to thrive in any kind of question stem is going to make you think something's wrong with that baby's heart. The other thing that you're going to look at, especially as you get older with the child, does the positioning matter? Does the positioning change the sound? Does the positioning change how the child reacts? So it would be if you're laying, sitting, and standing. It is not just for orthostatics in an adult. That can drastically change the way the heart sounds in a child laying, sitting, standing. Certainly if there's any extra fluid that's going through, you're going to continue, you might hear that with some crackles in the lungs, pulmonary edema. Very uncommon that you're going to see JVD, but if you ever see that on a test question, it tells you it's pretty severe. And then always, you guys have probably at this point learned clubbing, cyanosis, those type of things. Certainly if you see this as prolonged in a child, you can see this. The liver can back up, so we see a very large liver. It can take up a lot of that right side. If it's trying to kind of, so it's blood volume, so it's basically holding off. It's like, hold on, the heart can't handle this right now. So wait your turn, wait in line. And the liver just kind of gets bigger and bigger and bigger. So if you see that really large liver, it's indicative that the heart just needs a second. Same same with some endocarditis stuff. I'm going to leave endocarditis to Dr. DeVore. So he took care of that for y'all. So I know there's some slides in here, and we really won't touch that as much here. Pretty rare. For your sound, just review. Remember, you have your mitral and tricuspid valves that are closing for S1, your aortic and pulmonic for S2. And as you inspire, you'll hear a slight split. So it will sound S1 together, close, close, close. And note that split, it's wider with inspiration. So the way I think about it, it's not quite right physiologically, but if you're taking that breath in, you're trying to get all of that blood that you all of that blood that's going right by oxygenated with that breath, and so it'll stay open just a little bit longer. So inspiration is going to increase your split. If it's open all the time, if you hear, wait, that's an S1, and then like a double tap, right? S2 is split all the time. That only can be an ASD. That means that the pulmonary vasculature is getting over-circulated. So it's trying to stay open longer to account for that, because I have this ASD that is just going right to left with every single beat. Okay, so a fixed split S2 can only be an ASD because of the over-circulation of your pulmonary vasculature. S3 is different though. Didn't you learn about S3 in cards? You learned it was kind of bad, right? Not so much in kids. In kids, you're able to hear some of their normal physiology. So they have very pliable hearts. The chordae tendineae, very pliable. Right? So you're hearing the reverb a lot of times. You're hearing the ventricles filling, the reverb of the chordae tendineae. You're hearing normal physiology often with S3. S4 I can't do anything about. Always pathologic. That is not normal. You should not be hearing ventricles during contraction. Right? So S4, it's bad in adults, bad in kids. S3, most of the time fine in kids, can be bad in adults. Clicks, are you still hearing the vowels that will click sometimes? So clicks will still be not awesome in kids, but sometimes can be something to be aware of. So certainly if you hear a click, it needs to be evaluated, but it doesn't necessarily mean like it does in the adult world. And then murmurs. So this always catches people. I'm going to tell you right now, there are test questions on this test and on your phase 2 tests about murmur gradations. So you will need to know this for phase 2 as well, not just for PEDS, it's in some of the other exams, cards tests, family medicine tests, those things. Okay. So when you're thinking about grades 1 through 6, we'll talk about that. So we're grading from I can't hear anything, I can barely hear anything, to anybody off the street can hear it. So somewhere along that gradient. Certainly it can be during systole, during contraction, during relaxation, or during the whole cycle. Systolic, diastolic, holosystolic. Obviously you want to know where you're hearing it the most, so your replacements, Dr. DeBoer went over. How intense is it? Anything over 4 on a grade had what? Remember what the difference in grade 3 to grade 4 was? Yes, a what? Palpable thrill. So you are feeling it. Right? That's going to be on the next slide. And then what does it sound like? Does that sound like something where you literally, like as a practitioner, you're like, ooh, that doesn't sound good. It'll just have kind of a musical or vibratory quality to it, right? Those kinds of things. And then does it change with your postures? It's going to be super important in PEDS. When we look at murmurs, this is the way I would usually think of this. So this will be a pro tip for if you're doing cards or any kind of internal medicine. Okay. If you say a grade 1 murmur, that should be like only a cardiologist can hear this. Okay. So like grade 1 is just like, wait, what? Like they have like a special stethoscope, they're like barely hearing it, right? So I think grade 1 is like cardiologists can hear this. PEDS cards. If you say grade 2 or 3, you're safe. So if you hear it and the patient in front of you is looking okay, you know it's a grade 2 or 3. So I can hear it. The patient in front of me is not dying. This is not badness. There's not something where I can feel that palpable thrill. I know it's a grade 2 or 3. So if you basically say grade 2, you're going to be fine on any rotation. Grade 2 or 3. So there's that line. So draw that line on your slides between grade 3 and grade 4, because that's really where it's no longer normal. So grade 3, 2, or 1, it's usually in kids, it is fine. Grade 4, you get that palpable thrill, not so much anymore. When you get into 5, you're hearing it with a stethoscope half off the chest. But when you're hearing it as a grade 6, we always joke, even a medical student can hear that. You guys are well above medical student level at this point. So if a medical student could hear it, anybody could hear it. Let's be honest. I say that before one time a medical student, if I could hear it. Things to get in kids. So chest x-ray is always an easy kill there. As you can see the generalized size and shape of the heart. You can see, is it big? Is it taking up more than half the chest? What does that aortic arch look like? It's kind of non-specific, but it'll give you a general size. Get some pulmonary vasculature markings and some edema there. You can always get your ECG. This tells you the electrical system. So if you think about the heart like a house, you have plumbing, you have electric. So you need to make sure, is my plumbing okay? Is my electric okay? Which one is messed up here? Again, non-specific findings. We'll talk about several of those with different dysrhythmias. And then echocardiogram. So this is a big difference from children to adults as well. When you guys are going to be out and about as PAs, you are going to send patients for echoes, not infrequently. Okay? You are going to say, hey, oh, I need to get a chest x-ray on you, I need to get a EKG on you, I need to get an echo on you, like it'll be nothing. In pediatrics, I have to refer to cardiology if I want an echo. And so that is a difference. Cardiology is going to evaluate and see the patient if I truly think that they need an echo. So that is going to be one of the things that will vary a little bit. You can definitely do cardiac caths on kids just like you can adults, but often since it is very invasive, we do it only in instances where we very much need it for very different reasons than you guys would be doing it on adults. So, murmurs, electrical or plumbing? It's the plumbing system, right? So a murmur is telling you something in the plumbing, something in the anatomy is not correct necessarily. Is that true though? So when I say the word murmur, all I am saying is that I am hearing blood flow. That is all that I am saying. So when people hear the word murmur, it's much like pseudotumor, right? When you hear pseudotumor, they immediately are like, I hear the word tumor, this is bad. When people hear murmur, they think of their 97-year-old great-grandmother who had a new murmur and died in the ICU. That is just what people think. You hear murmur, heart, bad, right? So your job as a PA will need to say, all this is doing is that I'm hearing the sound of blood flowing through the heart. And that can be very normal. When you're hearing blood going through the heart, you're just listening to their physiology. So when we say that there are functional murmurs, or benign murmurs, or innocent murmurs, we are saying that this child has such a healthy heart and such a small structure that you can hear the normal physiology through the chest that you can't hear in an adult. That's what a functional murmur is. You're hearing the normal physiology that is happening. So when we're talking about some of those, and we'll look at some of these on the next slide, a venous hum, normal physiology. Stills murmur, normal physiology. Pulmonary flow murmur, normal physiology. What you're hearing in a pathologic murmur is when the anatomy is not correct. You're hearing the abnormal physiology. So you're still hearing the blood flow, but now it's pathologic because the anatomy is not normal. So when I tell a patient, I'm hearing a murmur, and they get those big eyes, and they say it's just the sound of blood flow, and they still say it sounds bad, I say, think about when you flush your toilet in the house. Does that mean that your pipes are broken? Say no. Say no, when you flush your toilet, you can hear the water going through the pipes, but it does not mean that they are broken. It just means you can hear the water going through the pipes. That is what a functional murmur is in a child. Pathologic ones, all of those at the bottom, you're looking at abnormal anatomy. So all of these lists, you will need to know these lists, are the normal, benign, functional, physiologic sounds of murmurs in a child. So if I'm looking at a stills murmur, I am truly hearing the sound of the systolic contraction and relaxation of these ventricles. I can hear the vibratory sound of the heart working like it should. So I'm hearing that at the apex of the heart. I am hearing it, it sounds very musical, it sounds very rhythmic, it sounds like this child is doing great. When you have a fever, do you think that it is louder or softer in this child?
It's louder.
Why do you think it's louder?
Because
they're tachycardic, yep, so you hear more blood going through at a faster rate. That's perfect, yes. So what you don't want to do is you hear this grade 2 or 3, because you're never going to be wrong for grade 2 or 3, right? Murmur in a child, and you don't tell the family, and now they go to the ER because they have a fever, because that's 1/3 of the visits we see in PEDS, and some provider who hears this and doesn't know that they normally have a functional murmur says, did you know your child had a murmur? And now they hear the word murmur in the setting of a fever in an ER, and they're totally freaked out. That is why it's very important to talk. If you hear those type of exams, normal setting to talk to them about, hey, this is normal. This is the sound of physiology of the heart. So when they go to the ER and it's 12:30 in the morning and somebody says, do you know your child has a murmur? They say, oh yeah, I do. And it's going to be worse than a fever. Got it. Not freaked out. That's what you're hearing, the Stills murmur. Completely normal, ventricular, apex of the heart, musical and quality. Totally normal. Those little kiddos, those 3 to 6-year-olds, kind of early school age. Your venous hum. This one's interesting. You are literally hearing the constant blood return in the veins. So if you hold your stethoscope up to the jugular vein, you can literally hear the humming of the blood returning to the heart. It's going to be more when the patient is upright, because you're hearing that blood flow go more, and it should be just continuous. You're in that same age range, just their normal physiology of the blood return. You can hear a carotid bruit. You're like, wait a second, I thought that was bad. Like, it's okay in a kid. You're hearing that systolic ejection noise, normal physiology in a kiddo. Any very compliant vessels, very compliant hearts. In adolescents, you can hear another, again, systolic ejection murmur. So if you're noticing all of these are systolic, none of these are diastolic in nature. And then finally, peripheral pulmonary stenosis. The way I think about this, the reason we started with fetal circulation is that as in that fetal circulation, none of all those teeny tiny little blood vessels are filled yet. And so as they breathe and as those vessels start to get full of blood, everything's kind of stenosed and still opening up over time, and you can hear all of that opening. Not quite how the physiology works, but it helps me always remember that's what I'm hearing. I'm hearing the lungs fill and expand for the first couple of months. So usually very, very, if you're still hearing it after about 4 months, you start to think, hey, do I need to look at something? But a systolic murmur that you hear in the back, because that's where all that pulmonary vasculature is, and peripheral pulmonary stenosis. So all of those are completely normal. Normal physiology in a kiddo. Normal functional murmurs. This is just an indication of where you're hearing them. So again, that venous hum that you're hearing, you can hear it down in the neck. If you're hearing it over the apex, Stills murmur, you can hear it kind of going in that direction of where the aorta is going to go. And then in the back for the pulmonary branch stenosis. Those particular 3 are places to know about. If you're doing a physical exam, where you would expect to be hearing this. I think we went over that. Please go over this with a family, especially if you're on your pediatric rotation, you're like, I hear something. Or if you're in the guard or reserve, you're going to be out, you see children. Just let them know so that they don't get an entire workup in the ER in the middle of the night. They don't need it. It's just a noise. Doesn't mean that their anatomy is off. It means you're hearing the normal physiology. Chest pain in an adult. You worry, right? Chest pain goes to the front of the line. Everyone says, oh, chest pain, it's cardiac in nature. Do you think chest pain is often cardiac in nature in a child? No, not at all. These kids' hearts are super compliant, super healthy hearts for the most part, right? Congenital lesions, there's 1 out of 100. It's really not that many. And so you have, most of the time, it's not cardiac in nature. You're like, well, what is it then? Well, let's look at those red flags. So just like headache had those red flags, cardiac does too. So when do I actually think that this child in front of me is having cardiac chest pain? Well, if they're doing something and they're exerting themselves, I'm playing soccer and now I go down and my chest hurts. So chest pain with exertion, that's a red flag. Chest pain and I syncopize, if I pass out and I have chest pain, that's more likely cardiac in nature. They're telling you I have those palpitations, I feel a funny beat in my heart, I feel something in my chest, it's fluttering, there's a bunch of different words. That's more likely cardiac in nature. And then my chest hurts and I have a fever. Sure, that could be pneumonia, that could be something else going on, but a new onset true chest pain, localized, and a fever makes you think it's more likely it is cardiac. Myocarditis, pericarditis, something to that effect. So those are your red flags. Please be aware of those red flags. Pick those out if I give you one of those. Otherwise, less likely that it's cardiac in nature. certainly could be anxiety. Certainly if they have an early family history of something going on. And then your differential is going to look, what other systems could this be? Right? Just like any other chest pain, what symptoms could this be? If you're looking at that differential, please don't spend your time memorizing this differential. It's not the important part to take away. The important part is, in a child, if I'm saying I have chest pain, it's often my actual chest. It's often musculoskeletal. Things are developing. I have costochondritis. I'm growing, right? So as a child, it's often truly musculoskeletal chest pain, chest wall pain. Next, it's more likely that it's pulmonary in nature. Do I have asthma? Do I have a pneumonia? Am I coughing? Do I have a pneumothorax because I'm tall and skinny male, right? Something like that. Then next, after that, it's going to be GI in nature. You all talked about that, from GERD, all kinds of stuff for those kids. And then we start getting into, maybe it could be cardiac. So whereas chest pain in adults, it's heart until proven otherwise. Chest pain in kids, it's probably not cardiac. It still needs to be on my differential. I still need to make sure I don't miss those red flags, but it's more likely all of those other things before cardiac in nature. It doesn't have those red flags. So again, please don't memorize this differential. Just again, to be aware of the categories as involved. EKG or ECG though, always appropriate. Is that checking the plumbing or your electric? Yes, you're checking your electric here. So most of the time, if you have a normal electrical system, you know everything else is going to be okay. Again, if they need to have reassurance, this is one that often, since the heart is such a big deal for families with family history, people have had scary scenarios, a lot of times they do need reassurance from the cardiologist, and I will write that in my referrals. I will say, dear pediatric cardiologist, this is a 7-year-old male, and I'd say, none of the red flags, normal EKG, referring for parental reassurance. And they just sometimes need to hear it from a specialist. That is okay. That is okay. That is not one to die on, unless you as a provider want to. That's one thing too. Not what I do. So, I give polytrim drops for viral conjunctivitis, and I send them to the cardiologist if they need reassurance. It's just me. You practice how you want, within the standard of care. Dysrhythmias. Are we talking about plumbing or electric? Electric. Electric. We just talked about most of the time their anatomy is normal. So do I expect there to be a lot of dysrhythmias in pediatrics? No, not really. It's pretty uncommon here. If something is going on truly with your electrical system, most of the time there is something truly going on. They have an acute infection. They have an acute electrolyte that is abnormal. They have an acute process. There is some sort of underlying genetic reason that something is going on. Or it's a normal variant. So I know in pediatrics you guys get so sick of hearing about the normal variants. Like, why are we learning these if they're normal? Because they look abnormal, but they're not always abnormal. You're thinking sinus arrhythmia. So sinus, what does sinus mean? So P wave, where does it originate from? Yep, your SA node, your sinus node. Is that normal or abnormal? That is very normal. So if I have a sinus arrhythmia, I by definition am saying it's a normal abnormal. That's literally what sinus arrhythmia is. So I'm saying it's an asymptomatic dysrhythmia, meaning this is a normal variability with breathing. So it's going to increase with inspiration, decrease with expiration. It's always from the SA node. It's in a regular pattern. It slightly increases or decreases with breathing. What did that S2 sound do with breathing? So inspiration, it does what? Splits. Right? So when you inspire from a physical exam standpoint in a child, you should hear that split S2, and you should see a sinus arrhythmia with that lengthening, increasing time. Those are the two things you'll see. Both normal. You don't need to do anything about it, but note it. The other three that are functionally pretty normal atrial dysrhythmias. So you see a wandering pacemaker. So the first two, I really describe them to parents as your child's heart is still figuring out how to do this, right? You just bought a new house and you're like, well, that's a weird light switch. It's backwards. It's upside down. Like, I need to fix a little bit of this. And it takes a little minute to kind of settle into this. So what a wandering pacemaker does is you have this different type of morphology of the P wave, but ultimately the P wave still leads to a QRS complex, right? So ultimately it still does its job. You're just like, well, that's strange. It takes a little bit to settle out. So nothing that you need to do there, no treatment, no workup. It's a little bit different than premature atrial contractions. So in this one, it happens in the NICU setting. And I think of this as the NICU, these early babies, where the P wave gets really excited, and then everything else just tells it to hold on. So you'll have a P, QRS, P, QRS, P, right? It's just like the baby was early, their premature atrial contractions are early too. And as the baby gets older, it's like, I don't need to do that. I can just have regular P, QRS. Right? So I have a functional premature atrial contraction in a premature baby. As their heart over time develops, gets a little bit older, matures, the structure matures, the premature atrial contractions go away as well. So you probably won't see that unless you're in a NICU. It's an entity to be aware of. And then atrial flutter and fibrillation, that's fibrillation, that's going to look the same adults and children. Very uncommon in the pediatric setting, but something to be aware of. And when you truly do have some sort of cardiac entity, so a myocarditis is going to be your most common thing, where the tissue itself is inflamed or infected. So just an example of what that EKG would look like, ECG, the wandering pacemaker, right? P waves up, the P waves down, P waves up, it's just a little bit all over the place. Premature atrial contraction, same thing. You see these kind of early P wave, got real excited, it's just early, and then flutter and fibrillation, your normal things. The one that I really need you to know, star, highlight, underline, this is the one you really need to know, because this one is not normal. It's not one that you can just say, this is totally fine. So this one is symptomatic. The other ones that we were looking at, the baby doesn't care. The child does not care at all. This one is very symptomatic. If you had this irregular rate, so meaning a regular rate, it's starting from that SA node, but the rate itself is like 220, right? What happens if your heart is beating 220 times a minute? What can you not do? Diastole. What happens during diastole? It's filling, yes, your coronary arteries are filling, and the rest of the heart is filling. So in your next beat, there's not much to beat out. So eventually you kind of run out your pump. If you think about that like an engine, there's no gasoline in it, eventually that pump is going to not work anymore. Very similar to this. You're going so fast that you can't fill, eventually that baby is going to get out. And the infant rate is so much higher even than the adult rate. 220 is like staggeringly fast a minute. Can be up to like 300, like 300 beats a minute. Do you understand how fast it is? That's incredibly wild. So eventually, again, they will, after several hours of this, you end up with this poor cardiac output and heart failure, and really the baby will just move out on you. So the thing to look at is, are they stable or are they unstable? So if you get this, you're feeling pulses, or the baby, more commonly, the parents will come in and say, they're just not acting right. They're not eating right. They seem really tired today. They seem really lethargic, right? A true lethargic baby with a rate of 220, is that a stable or unstable baby? Unstable, right? Truly lethargic baby, that's an unstable baby. So when I'm looking at that stable baby, it might be somebody that I caught early, or I caught while they're inpatient, I caught while they're acutely sick, or it's early manifestation, right? So if I'm doing vagal maneuvers, what does that actually mean on a baby, right? In an adult, you're saying, could you just hold, clamp down like you're having a bowel movement? How do I do that in a baby? What's next? How do we do vagal maneuvers in a baby?
Cry.
How do you make them cry? You could. If they're truly lethargic, you're going to try to use up their energy doing that. So a couple of things. You can do carotid massage. It won't work very well. Next thing you do is you literally hold the baby by the feet and hold them upside down. That will increase that pressure, and that will vagal the baby, right? You can't do that very long. I've held the baby upside down. Did that break the SVT? Probably not. So next, I'm going to do this ice to the face. Has anyone done ice to the face for a baby here? How do you do it? First time I ever got asked to get a bag of ice, I literally went and got to the ice machine, buy a bag of ice, and I gently put the ice around the baby's face. Yeah, and then the attendant came behind me, tied the bag, and smothered the baby. Okay, that's what you're trying to do. Why are you trying to do that? What is it doing? Yep, activating the diving reflex. So that's what you're trying to do. You're trying to startle them to activate that same diving reflex that you would see if you jumped in a pool of cold water that would slow the heart rate down. Right? So it has to startle them. So ice to the face, smother the baby. So after, this poor baby, having a hard day, you held it upside down, and you smothered it with ice. Right? This is a hard day for this baby. After that, then, if you have an older kid, you can have them blow through a straw. Never seen it work. Always seen this in a baby. Okay? So now, they're stable, and you have failed all of those maneuvers. I need to do adenosine. Do you guys remember how adenosine works? It stops the node completely. For about how long? Yeah, it's about 8 seconds. It's the longest 8 seconds of your life. And how do you give this? Fast push and followed by a flush, right? Think about a baby. If you're doing this by weight, if you push the 1 mil or whatever it is of adenosine, it's not even going to get through the tubing, right? That's why you need to have a push right after to make sure it even gets into the baby. And then if both of those fail, synchronized cardioversion. What happened? What do you need to be prepared to do if you do synchronized cardioversion? A full code. Yeah. Right? This heart has been beating that fast for that long with that poor cardiac output, and now you say, we're going to synchronize you. Sometimes that heart will just say, I can't do this anymore. So you need to be, if you do that, be prepared to code this child. Just know that side, know all the things. SVT, this is looking at a rhythm of what, 280, 250? It's incredibly fast. It's such a fast rhythm. Ventricular ones, a little bit less common in kiddos. You do see some PVCs, and again, these, especially older teenagers' hearts, super compliant, right? If you've ever watched like a high school teen workout, you're just like, how are you guys still doing this? Have you not thrown up yet? Like, how is this possible? Right? So they have very compliant and healthy hearts, and sometimes their rates will get down so low that they will activate a junctional rhythm. So it's no longer from the sinus node. Their hearts are so heavy, they're so healthy that the SA node is saying, I'm still good, and the junctional rhythm pops up and says, are you sure? So you get a ventricular contraction because their hearts are so healthy. So you see these PVCs in these older adolescents, usually benign. You just don't want to see them stacking or more than a burden of about 12%. Right? So if you do an EKG and you're like, wow, 12% of all of these are PVCs, that's when you start to get worried. Otherwise, a PVC here or there can be uncomfortable, but normal. And then certainly ventricular tachycardia, if you have more than 3 in a row, you should be prepared to code because something has gone drastically wrong. So that's not normal, and that will be have PALS. Which is a plug for PALS. If you go to any of your phase 2 sites, they say, we have the opportunity for you to get certified in PALS. Even if you're not going to see a child, it's just more exposure, and it's just a chance to get some reps in. So please get certified for PALS if that's an option. Do it for me, please. Okay, and again, what that PVC looks like, VTAC, and then VFib. VFib is going to be VFib whether you're an infant, a child, an adult, geriatric. VFib, no bueno. So we're looking at heart blocks. The heart blocks are the same. So a couple of differences here. So very quick overview. Your heart block, prolonged PR interval. So it's still from the SA node. It's just a longer difference, a longer distance, and then your QRS. It's type 1. Every QRS is followed by a P wave though. Your type 2, your Mobitz type 2. So you have a couple of different ones. So you have progressive elongation. So it's getting longer, it's longer, it's longer, it drops, right? It's going, going, gone, going, going, gone. Versus your type 2, which is like duck, duck, drop a goose. Right? Duck, 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 goose. So it's usually in the same 2, 3, 4 patterns. Duck, 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 drop. Duck, 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 drop a goose. That's how I always remember that. And then type 3. So this is the one that I really need you to remember. So type 3 is when they are not connected at all. I'm thinking, yeah, well, we don't even really see that in adults. There's one entity in kids. We really do see this when there is no relationship between that atrium and the ventricle. Something has severed that connection. So what has severed that connection? We'll talk about that. As a reminder, just from Dr. DeBoer's class, what a type 1, the two types of type 2 and type 3 look like from AKG or ECG. The type that is the type 3 heart block, where you have no relation between the atrium and the ventricles, happens when mom had lupus. So if mom has maternal lupus while she's pregnant, those antibodies that her body makes can cross the placenta, goes over here and attacks between the SA node and down into the ventricles. And so now you have a functioning SA node and a functioning ventricles, they cannot talk. So complete heart block in a neonate is probably the result of maternal lupus or maternal Sjogren's, some sort of autoantibody disease that has attacked the baby while mom is pregnant. And this child in the NICU will need a pacer, and will need a pacemaker for the rest of his or her life. Maternal lupus can have devastating consequences to this child. So a complete heart block, you need to think maternal lupus. It goes together in your mind. Which takes us to our congenital cardiac disease. And this is my favorite part. I think what time did we go till today? When is my 2 hours up? Do you guys want another 5 minutes? Do you need another 5 minutes? Or do you just want me to talk the whole time? Okay. I know you guys look different today. I'm so jazzed about your congenital cardiac. It's just so good. Okay. So when we're talking about what does acyanosis mean? What does acyanotic mean? Not blue, not cyanotic. Okay, so these babies, acyanotic means you have a pink baby, which means that all of your lesions are going left to right, and going from oxygenated to not oxygenated. So I'm sending oxygenated blood back to the lungs to get more oxygenated, which doesn't work like that, but that's the way to think of it. So not blue babies. So these lesions are all not blue babies originally. You have a ventricular septal defect, atrial septal defect, PDA, your stenosis, and then your COA. Okay, so we'll talk about all of these in detail. But all of these are going from that higher pressure left side to lower pressure right, acyanotic. When you're talking about your VSD lesions, so this is the most common thing. So if you are ever on a board exam and you are thinking, okay, congenital cardiac disease is only 1 out of 100. So out of every 100 babies that are born, 1 baby is going to have something structurally wrong with the heart. So this is now plumbing. So we talked about the electric, and I wouldn't be a very good electrician. That was all electric. Now we're in the plumbing. So 1 baby out of 100 has something wrong with their anatomy, congenital cardiac. The most common of the 1% is going to be your VSD. So this is your most common thing. So if you have to guess on a board exam, you have to guess somewhere, what do I think this child had? VSD is your best guess. The bigger the size of your defect determines how symptomatic you are. So which one of those is really functionally the loudest? The less than 3 millimeter, 3 to 5, or the greater than 5? Yeah, the small one is super loud. It's that same concept again as if you put your thumb over a hose. So high pressure pressures, but not that much volume is really getting across, and it's loud. So it's often asymptomatic, but you're hearing a real high-pitched kind of squeak almost. Some moderate symptoms, if it gets a little bit bigger, then anything over about half a centimeter, you're really functionally looking at a lot of blood flow going from that left side to right side, recirculating the lungs, and you end up with that congestive heart failure physiology, and functionally, your child is in failure to thrive. When you're listening to this, it sounds really harsh. It doesn't have that musical, vibratory quality that a Stills hammer has. It sounds harsh. It sounds like something is going upstream, going backwards, because it is. So it's a really harsh sounding 2 to 4, 5, and it's all the way through systole, right? The ventricles themselves are contracting all the way through systole, pushing left to right, with that lower left sternal border, right at the bottom of that septum. Ventricular septal defect. Most of the time for your small ones, you're going to see pretty normal everything. So pretty normal. You might see a little bit of enlargement on chest x-ray because everything is over circulating and all those muscles have gotten bigger to compensate for that. You might also see some extra fluid in the lungs. So you're going to have that pulmonary edema or congestive heart failure as well. And these ones are going to refer to cardiology. And this is where I think it gets super, super interesting. This is why kids are so cool, because a third of the ones that have this hole in the heart, depending on if it's part of the, so there's 2 parts of the septum. There's a membranous part and then there's a muscular part. And if it's on the membranous part, that the kid's body will figure it out. And it will literally figure it out and close it on its own. So a third of these, they will literally grow out of this hole in their heart. Their body will close the membranous VSD on its own over time. That is so cool. Like kids are, that's amazing. Like it will just remodel like that. Your moderate ones, or if they're on that muscular part of the septum, they often will have to have some diuretics to get some of that extra fluid off. You can see which way is this going to go over time, so we need to go in and close that. And then truly, if you have this poor growth, failure to thrive, a large defect, or you get pulmonary hypertension, it's going to require that closure. Why are you getting pulmonary hypertension? Yeah, so the flow is going backwards. So it's going from the left ventricle, backwards where? Into the right ventricle. And thus, where do you go after the right ventricle? Yep, you're trying to go up to the lungs. And so functionally, the body says, nope, you've already come through here. You've already gone down to the left side and now you're back. I'm going to clamp down and say no. And so you have this pulmonary hypertension that ends up pushing that left ventricle, or I'm sorry, the right ventricle is getting larger, and thus your hypertrophy starts. So you have high pressures, pulmonary vasculature, on large side of both your right and your left. Left because it's having to push harder to get the same amount to the aorta. Right because it's having to take all that extra amount. And then the pulmonary hypertension because it's trying to clamp down and say, no, wait your turn before you come through here once. At least that's the way it talks in my head. I don't really know if pulmonary vascular talks like that. ASD. So again, not the same thing as your foramen ovale. We've already gone over that. So it's foramen ovale, super, super tiny to bypass the lungs in utero. So it's that normal hole. It becomes that patent foramen ovale if something fails to close. If that does it, it's not great. But if there's actual septal hole between the two, that's when you have your ASD. When there's something in the septum, not where the FO, foramen ovale is, if there's truly something in the septum, that's where you have your ASD there. Your ASD is usually much larger than your PFO, so something to think about from a symptomatic standpoint. And again, what do you hear at a physical exam if you have an ASD? Fixed, split, S2. Yep. If you just have a normal split S2 that comes and goes, what's that? Breathing. Totally normal with a kid. Breathing. But fixed split S2 is going to be that ASD. So rarely symptomatic, especially at first. You see this over time become so you're going to be great at that physics split S2. You can hear a murmur, but oftentimes you don't hear a murmur. Why not? Why don't you hear a murmur? Not necessarily the size, not necessarily the valves. What's happening when you would hear this? Systole, yeah. So you're not hearing it because you're hearing systole over top of that. So very hard to hear. So oftentimes you don't hear a murmur. Sometimes maybe you do, but really functionally you don't. What you can hear is that diastolic murmur of that runoff as everything is relaxing. And again, diastolic murmurs never normal, so that's usually what clues you in. So the fixed split S2 and that diastolic are the ones that make you think, something's not normal. Your chest x-ray, heart can again look bigger, so you have that over circulation, but this time it's not necessarily just your ventricle that's larger, your right atrium, because it's taking all of that left to right shunting back into the right atrium. Thus, you're going to get more in the right ventricle, more to the pulmonary circulature, so you have that hypertension again over time. So you have both right atrium and right ventricle, as opposed to your VSD that just had your right ventricle. Where's the lesion? What's it going to affect? That is why. Most of the time, again, this will close spontaneously. Kids are cool. Their body will fix themselves. They will outgrow this hole in their heart. Their body will remodel it. If they don't, and by the time you start noticing that they're having trouble keeping up, a lot of kids, they get treated for kind of a symptomatic asthma type picture. You treat and treat and treat and treat for asthma, they don't get better, they're still fatigued with exercise. No albuterol in the world is going to fix the hole in the heart, right? No ASD is going to be fixed by albuterol. It's actually going to get worse because now you've made them tachycardic. And so those are those kiddos that you end up going and saying, hey, we need to just close this up. And we'll put literally a couple of stitches in the septum to close it up, redirects their circulation, and they're good to go. Can do it with a catheter, very rarely needing to open these kids up. Super cool, ASDs. And then your PDAs. PDA, the next one, this is the one I wanted to tell you about. No, this one is the next most common. What was this bypassing in utero? The lungs. Yep. So you bypass the lungs, and what is it coming off of? Get the aorta over into that pulmonary vasculature. Or so it's going pulmonary vasculature directly to aorta. Now we're going left to right, so aorta back to the pulmonary vasculature. So most of the time, if it's small, again, you won't notice it. If it's large, see it does. Again, because you're dumping blood from the aorta back into that pulmonary circulatory system. Okay? Why does it have this continuous machine-like murmur? It's flowing back and forth. What does the aorta not have that the rest of the heart does? Valves, right? So you're not hearing any of the opening and closing of the valves. You're just hearing flow the whole time. So anytime you hear continuous sound like that, machine-like murmur, you know the sound when your washing machine is washing and it's just that continuous chug, that's what you're hearing with this. There's no clicks, there's no sound, it's just continuous that whole time. And it's upper sternal border, right where your aorta is. Why do you have a widened pulse pressure? What does that mean? We just say these words. Your increase in your systolic compared to your diastolic. Why do you have that? Why do you have to have higher pressure? Yes, because you're trying to get blood to the whole body. So you have to have increased pressure because you know a lot of it's going to run off the aorta and just go backwards. So you have to give it a lot of that forward pressure, and then it all runs off, and so you actually end up with a pretty low diastolic. So you have high systolic, low diastolic because of that runoff from the aorta. So that's what we're saying when we say a widened pulse pressure, and when we say continuous, because the aorta has no valves. So we're hearing it that whole time. Studies, most of the time it's small. You can't see this on an EKG. You can't see this in a chest x-ray at all. If it's significant, you might have that over-circulation of the pulmonary vasculature, so you might see some of that increased vascularity. If it is going backwards so much, you are getting that pulmonary hypertension, you will probably see that left ventricular hypertrophy too, because everything is going back. Indomethacin. What class of drugs does that fall into? NSAID, yep. So this is ultimately the reason why we say no NSAIDs in pregnancy at any stage of the pregnancy, because we don't want it to cross over into the placenta and shut the PDA in the developing fetus who's trying to bypass the lungs to be able to grow. That is why. So then conversely, when they come out and you're like, oh no, it didn't get the signal for it to close, we need it to close, we do give NSAIDs to close that down. That's exactly what I'm going to do. So most effective, the younger you are, so the more premature you are, the more likely you're going to respond to this NSAID treatment one way or the other. So the younger you are in utero, you are more likely, if a mom is taking a bunch of ibuprofen, to be affected by that. The more early premature you are, the more successful indomethacin is. The later you are, or if you're postnatal or out an infant among us, those are the ones that often will need the coil embolization or a PDA surgery to close it. Where are we? 402? Let's see. This will be perfect. We are so close. When we are talking about the stenosis, the stenosi, so this can be any part of the valve. So when you think about the valve, there's going to be above the valve, at the valve, and below the valve. Right? So 3 different parts of the valve. So you can have subvalvular below the valve, you can have valvular at the valve, and then you can have supravalvular. So any part of that can stenose. So it's important in cardiology with an echo will differentiate which part is really the stenosed part of that. So if you think about this, these valves are supposed to just open and close, open and close, open and close, right? 2 things we don't want. We don't want saloon doors that just allow backflow, and we don't want them to be open where they don't actually close, but we need them to open. So in a stenotic valve, it can't open. So it's doing that every time. I'm stenosed. Stenosed. And that is what you were hearing often with that click, is that stenosis that pushes it open every single time. That's why the dyspnea and fatigability, right? I did arms yesterday, and in like 3 of those, I was already fatigued. Kind of the same. Your valves will end up, it's a lot of work for them to do each time. These children end up easily fatigable. That's what you're hearing, the systolic. Every time it's trying to open, you're hearing that, and it's got that click there. Depending on which side you are, pulmonic, you're going to hear on the left. Aortic, you're going to hear on the right. With the stenosis, depending on where the vessels are going. Most of the time, again, normal, because EKG, again, is looking at your electrical system. There's nothing wrong with your electrical system in a valve. That's the plumbing system. So your EKG is probably going to be pretty normal. When you do have some of the stenosis, depending on how bad it is, your EKG can show you where's the backup. So if you have this stenosis on the pulmonic side, it's going to be backed up on the right side. So you have the right axis deviation. There's stenosis on the aortic side. It's backed up on the left side. There's the left side axis deviation. And your treatment is kind of cool too. These are cool surgeries. So they go in and they basically like put this balloon in there to basically like break up the stenosis. So it's kind of actually pretty cool and really good outcomes with that. So if you have the ones that have problems are number 1 if the balloon fails, or in subvalvular pulmonic stenosis. So those are the 2 that just don't respond as well, or the ones that really need an open surgery for that. Overall, these have really good prognosis. So they can be pretty profound exams. Once they have this treatment, we do really, really well. And again, that's acyanotic. So the blood blood is still going the correct direction, everything is still getting oxygenated, it's just having trouble getting to where it needs to go. Coarc is the last one of the acyanotic, so everything is still going the correct direction, everything is still getting oxygenated, so this is that last one. So most of the time, it comes right after the ductus arteriosus. So you have the ductus, and now we have this area that is just clamped down. So it doesn't necessarily have to be there, but that's typically where you're going to see it. And this should be a no miss. Every pediatrician should be able to catch this by the time they are 2 weeks old, because your exam should be 12 inches apart, where you have one finger on the brachial pulse, and one finger on the femoral pulse, 2 fingers. And if you're feeling those, and those pulses are not equal, you have bounding pulses in the upper extremities and not as much in the lower, you know you have a problem. So you could be able to diagnose this clinically, and you should be able to rule it out. Right? They should not come to the clinic where we were at as an 8-year-old, and somebody had missed this on every exam. That does happen, shouldn't happen. It should take a 5-second exam with your fingers 12 inches apart. Easy. And there's only so many ways to ask this on a board exam too. So femoral pulses are weak, or lower extremities have lower pressure than the upper extremities. Upper extremities are ruddy and red, and lower extremities are white and cyanotic. Right? There's only so many ways to ask that pressure differentiation. It can only be coarc. Same thing, so blood pressure there. The other thing that you will see on chest x-ray, if this happens over time, is going to be collaterals. So in that case, these kids' body's super cool again. I can't go right through that stenotic part. I'm going to just build new blood vessels to go around that. There's no room for that. That's okay. I will just make room. So if you're looking, rib notching, there was no room for me to go around. I will make room, and they will notch my way in right next to the ribs. So you'll see rib notching on exam or on a chest x-ray to account for where these collaterals have found their way around to continue down to the lower extremity. That is a picture, so right after the aorta, right where the narrowing is, you can see everything is still blue or red, nothing is purple. This one. Rib notching, I already said that. Again, it backs up. You can see it on the right side, farther, you can see it on the left side. Where's the lesion? And that is a picture of the rib notching. So if somebody gives you that, you know it has to be. You're like, there's not supposed to be vessels that are doing that. So if you see that, you know those vessels have eroded their way as a collateral to get down into those lower extremities. For treatment then, okay, it's right next to that ductus arteriosus, so we talked about that. And we said prostaglandin props it open. So we're propping open that ductus arteriosus to make it so that you still get that bypass into the lower extremities. So if you have a known coarc, and see it on a baby's ultrasound, you're fine because you still have that ductus arteriosus in utero. When they come out, we need to correct that. But before we corrected it, we will bypass it, keeping it open. So prostaglandin, this is one of the ones. So this is one of the ways to study this. What's going to need prostaglandin? Coarc is going to be one of them. Coarc needs prostaglandin to prop it open, to bypass that stenotic part. The surgery is kind of interesting. You can do a couple of things. You can either do the balloon again, so the balloon angioplasty to open it up, or sometimes more common, they will go in to the side, they will cut them open, they will snip, anastomose, and we're on our way. So these kids do excellent. Something to think about if they do have a scar on that aorta. Is that a weak place for the rest of their life? This is a good stopping point. When we get to the cyanotic lesions, thank you guys. I know